Okay, hi everyone. Most of you know me already, but I'm Mark Toshner. I'm one of the Joint Chief Investigators of Heal COVID. So today we just thought we'd go through some of the eligibility criteria, because there is, in a trial where we have set some very intentionally, what's the best way of wording it? Open criteria to try to keep it as inclusive for as many patients as possible. It's really a pragmatic effectiveness trial. So the intention was to make the trial as applicable to real world as we could, but it has definitely led to some grey areas where there is variability of interpretations of some of the criteria, and the same things keep coming back to us week after week in the PI meetings. So we thought we'd just go through some of those common questions and talk about what we're doing to try to improve in any lack of clarity, but also to address some of the usual reasons that people have difficulty with participant recruitment and with some of the eligibility criteria in particular. So just a quick update, that what we're going to do is we'll tell you where we're up to with recruitment. We'll talk about some of the work that Joe, who I'm going to hand on to, we're going to tag team it. So I'll do the first introduction, then Joe Newman, who's my PhD student, is going to talk to you about some work he's been doing, some qualitative and quantitative work trying to understand the problem. We'll go over the inclusion-exclusion criteria again, and then we'll take some actual FAQs and go through some real-life scenarios together, the two of us, and largely we're going to finish in the API scheme. And I know I talk about it every 2 weeks or so, but it really has been a really positive feature, and we just wanted to remind you about it. And Joe's going to make mention of Twitter because he wants to wind me up. Good. Okay, so update and heal. This is just, rather than just give you the numbers, I thought I'd give you a rolling total over the course of the last 6 months or so, or in fact coming up for, I guess, a year quite soon. And this tells a pretty good story, which is that we did an excellent job recruiting through Delta, but we've really struggled in the context of the Omicron wave. So we hit Christmas and we're recruiting at about 40 to 50 patients a week, above our self-imposed targets, but really since Christmas we've found it difficult, and we've talked about this a lot in these meetings, and that is multifactorial, but definitely there are different interpretations of the population that we're after, and so today we're going to clarify that today again, but in a wee bit more detail than normal. And just a reminder that there are still loads of patients out there. Now, we know that admission rates are still reducing, but remember, HEAL isn't just about patients that are admitted, it's about patients that are still in the hospital, and there are still, in the better part of 7,000 patients in the hospital. So if we captured 15% of those patients, would be close to finishing the study, within weeks, and people are still dying, and that's an important point, because although I think the general messaging around COVID is that it's now flu-like, that is not the case, sadly. Although from a number of metrics you can compare it to flu, the burden of disease out there means it's still a significantly devastating disease from both the mortality and the long-term morbidity perspective. So there's a real need still for HEAL, and in fact HEAL is the only show in town, and it's almost the only show in town internationally, because we are miles ahead of everybody else, and we know that because we have regular discussions with our counterparts and colleagues in the States and Europe who come to us to ask us what we think they should do. So at that point, I'm just going to hand on to Joe, and I'll come back towards the end. So we're going to swap over.
So, thank you, Mark. So for those of you I haven't met, I'm Joe Newman. I'm a clinical research fellow in Cambridge with Mark. One of my involvements with HEAL has been working with the APIs, forming a network across the country. So I just want to present a couple of slides from a survey that we did with the APIs back in March. So at that point, we started to recognise that the recruitment for the trial was starting to plateau and tail off. And we had some ideas of why, but we thought we'd ask the APIs for some on-the-ground feedback of any barriers that they've come across. So I won't go into too much detail, but just to highlight a couple of things here. So we just asked them quite openly, what difficulties do you have in recruiting patients to HEAL? And just to caveat that, this was back in March, so 2 months ago. And of the options that we put out there, most of these were agreed with. The most overwhelming response here was that patients coming into hospital test positive for SARS-CoV-2 virus, but don't have COVID-19 per se. So they might not be symptomatic, or they might not be in hospital with a primary reason of having COVID. And that's something we'll come back to later on in this talk, because that's a really common area of confusion when it comes to assessing eligibility. But some of these other factors we know also play into making life a little bit tricky at times for recruiting clinical patients. That's staffing issues, the fact that the demographics of the patients may have changed over the course of the pandemic, and then things like language barriers or patients who lack capacity to consent to research. And again, throughout this webinar today, we're going to come back to some advice about how we can get over some of these hurdles. One of these I just wanted to highlight was about the difference in the perception of the drugs that are involved in the trial. So just to recap that, we've got apixaban as a 2-week short-term treatment post-discharge, or atorvastatin, which is up to 12 months. And one of the things that was fed back to us was that sometimes patients, for example, might not be keen to take what they see as a chronic treatment. I think that's particularly applicable to young, otherwise fit patients who are probably not into the routine of taking long-term medications. So that's something that we had to think about. And again, that's something that we can talk about later on. Again, another slight obstacle to recruitment is the 5-day guidance of recruitment just prior to discharge, so within the last week of an admission. But again, just to highlight one of the takeaway points from today, that is just guidance, and the protocol does allow for patients to be recruited into the trial earlier in the admission, if logistically that's more straightforward, and quite often that probably is the case. So something to bear in mind. And another thing is that we know that patients who are more open to research generally, so those who may have already recruited to take part in recovery, for example, or remap cap, are the sorts of patients who may also be interested in taking part in HEAL. And these two work in harmony really nicely. So recovery is an inpatient study, and HEAL as a post-discharge outpatient study. So unofficially, thinking about approaching patients for both studies at the same time can make for quite an efficient approach to recruitment. And again, that seems to have played out from the responses from the APIs. Okay, so probably the most important thing just to flag up on our website, if you haven't already seen this, is where to find the key resources, which will help you with assessing that eligibility in the first place. So you should all have logins and have done the training, but even if you haven't, there's open access, freely available versions of the protocol. If you just click on for staff, and then this page comes up. The most up-to-date study protocol is in that blue suitcase logo, and then there's 3 red arrows at the bottom highlighting the standard adult patient information sheet with consent form, which would probably be for the majority of patients. And then just next to that would be for patients who lack capacity. So it's basically exactly the same, but worded for patients' family members. And just next to that, one for if a medical professional is acting as the legal representative for the patient. And that's all really conveniently located all on the same page. Okay, so we thought, rather than going through the protocol eligibility criteria, which could be a little bit dry and it's all there for you to have a read through, what we thought we'd do is make this quite a practical clinical session. So for the meat of the rest of the talk, really, I just want to flick through some quick fire questions which we've had from a number of you over the last few weeks who've emailed in, again, particularly the APIs. of common, slightly tricky scenarios that people ask for guidance on. So what we'll do is run through some of these, and again, these are all real life questions, and sometimes simple but common misconceptions, which we hope we can try and clarify. And perhaps if we take any additional questions at the end, it's probably going to be the easiest way of doing it. Yeah, thank you. Just swapping copies with Mark. Thank you. Okay, so Mark, first off, first patient is already taking both a DOAC, so rivaroxaban, apixaban typically, and a statin prior to coming into hospital with COVID-19. Could they be enrolled to just the one standard of care arm?
So that's a straightforward one to start with. The answer is no. And this is a relatively uncommon reason, actually, in the end, from the centres for patients being excluded. More often, it will be related to the DOAC arm alone, and I think we'll catch up on that later on. But I think if you're on both therapies, that one's quite straightforward.
Okay, so next up, we have a patient who comes in who does not have any typical respiratory symptoms, so no cough, no breathlessness, but they present with another presentation. So typically, PAP-based, we might see some cardiac presentations, so chest pain and myocarditis. Would they be eligible to take part?
So we were intentionally specific in not defining the symptom set in our inclusion criteria. So it is symptomatic disease, which is in the hands of the investigators. And so we have, in some ways, devolved responsibility to the investigators to say, I think the patient has primarily got a COVID-related presentation or not. But we don't require patients to have the classical pneumonitis triad or the classical pneumonitis presentation, because we knew at the start that the disease was likely to change. And in fact, everybody out there in the coalface is very clearly telling us that the presentation now looks nothing like the presentation from the very start last year. So I think we were right to do that. So as long as you're happy that the patient has symptoms ascribable to COVID and that they have symptomatic disease, then they're eligible. So the short answer to that one would be yes. If you're happy and clear that there's no other explanation and that they have symptomatic disease, then they would be enrollable, because we know that population still has a significant burden of both morbidity and mortality downline.
I suppose bearing in mind the multi-system effects of COVID here, so the renal complications, the gastro, the neurological, all sorts of things, stroke. And
a lot of people telling us that GI upsets are now quite a prominent feature of quite a lot of patients' presentations. And again, that would be perfect within zone as long as you're happy and convinced that that's the explanation for their symptoms.
Okay, next up, we have a patient who's been admitted to, for example, an assessment ward for 24 hours. Can they be enrolled?
Okay, so I think this is my and our biggest failure in our inclusion exclusion criteria, and I think maybe we got a little bit too clever in how we phrased this specific part of the protocol. The 5-day thing has confused people, and there's no question about it. Even though every week when we sit on these calls, I try to clarify what the intention was about it and why we worded the way it was. And we're going to change it for the next protocol amendment. So we're going to take the 5 days out, because the only reason that we specified a time frame was so that we made it clear that you could enrol patients, for example, on a Thursday or Friday if you're still expecting to discharge them on a Monday, but that the patient should be on the improvement part of their trajectory, because the closer to enrolment, the closer to discharge enrolment, we enroll them, the better. So what we've done is we're just going to say admitted patients with an expectation of discharge. So that in the amendment we will make sure the wording is nice and tight, but we're taking out this 5-day thing because it's slightly confused people. And so, for example, that patient has always been eligible for the study, and you don't need to be expected to be in hospital for 5 days. And in fact, we know that that's one of the major things that's changed over the course of the last few waves, is that patients are now in for a much shorter time frame. And I guess when we first wrote the criteria, most patients were in for 5 days to a week, so it didn't seem an unreasonable thing to specify that you're in towards the end of your admission and give you a time frame. but we always said that time frame was a projected, and it was never a defined. So basically, if anybody's admitted, they are eligible for HEAL, and maybe we'll talk a little bit later as well about recovery and HEAL enrolment, because I think that's also caused some slight confusion.
Okay, so next up, for example, we have a patient with lots of comorbidities, COPD, diabetes, epilepsy, etc. So quite a complex comorbid patient. Can they be enrolled?
So I would argue that actually they should be prioritised, because we know from every study that's ever been looked at hospitalised patient groups that higher comorbidity burden leads to worse longer term outcomes. So not only can they be enrolled, but this is somebody you should really be targeting. And of course they'll be on multiple drug therapies. You'll have to check the drug therapy list to make sure there's no hard exclusion criteria, and there may be some drugs that you're concerned about interactions with. But this is a patient who I think you should be prioritising and not thinking about it the other way around.
So none of these listed conditions here would cause any concern in themselves for HEAL. The one thing to flag up, I find, on a practical level, is liver disease for both the apixaban and the statin. But again, that should be kind of self-evident once it's cross-checked with the protocol. So similarly, we've got a patient here with polypharmacy. So an elderly patient on a whole load of drugs. Can they be enrolled?
So again, I think it's the same answer to the last one, which is that just go to the protocol and make sure they're not on any drugs that would exclude them in enrolment. But that this is probably a patient who should be prioritised, because by definition, polypharmacy goes in hand with comorbidity, and both of these go hand in hand with worse outcomes in the medium to long term. So short answer to that is yes, assuming there are no hard exclusion criteria from the perspective of the drugs list.
So I'm sure there's probably a number of pharmacists on the call today, and I've found recruiting patients with a friendly pharmacist close by has been invaluable for kind of quickly cross-checking any obvious interactions, particularly things like antifungals I've run into recently, and things like that. So always something to bear in mind. Okay, next question. This patient does not normally take an anticoagulant drug, but they do take other drugs that may increase the risk of bleeding, so antiplatelets, NSAIDs, possibly SSRIs. Can they be enrolled?
So this is a good question, because it comes up in a number of different formats and different drugs, and the underpinning concept of it is clinical equipoise. So, for example, an NSAID or an SSRI, you could withhold them for the 2 weeks period that they're on anticoagulant if you felt that was appropriate. There is nothing to exclude you enrolling somebody who's already on dual antiplatelets, but again, you have a duty of care to your patients, and it is built into the protocol that investigators can exclude patients at clinical discretion. So the short answer is yes, they can be enrolled, but then the more nuanced answer is there is still your good practice guidelines that you have to be happy that you have equipoise for the treatment and for your plan for the treatment.
Okay, so another common question. This patient does not have a complete set of baseline bloods. Can they be enrolled without, for example, an ALT?
And the short answer to that is yes, they can. And that has been through the MHRA, and they did not require us to do that. And in fact, in clinical practice, we don't get liver function tests in absolutely everybody that we start on statins in the real world either. It's relatively rare, if we're dead honest, for a patient to come through the hospital and not, with COVID, not get a set of liver function tests at some point. So this would be an unusual occurrence. It's not an exclusion, and you're not required to do it as part of research bloods. So the short answer to that again is yes, that patient can be enrolled. But again, if you feel your local practice would require you to have a set of baseline bloods, you're very within your rights to just order a set of liver function tests, but it's not required in the research schedule.
And it's just a very simple box on the eligibility form. You just tick bloods not done, and it just skips over that. So you don't. It's not a mandatory field on the form to complete it. I think that this patient lacks capacity due to a previous stroke. Can they be enrolled, and if so, how?
So that we have quite extensive mechanisms for consent, including both the professional and the personal legal representative routes. And again, this is a patient who's high risk, and so there will be a variety of local interpretation about whether you are comfortable with enrolling these patients, but they're at a high risk of complications. So again, the short answer to this is yes, they can be enrolled, and we have an extensive framework for doing that, and it follows the same schema as the recovery trial. And we'll talk, I guess, in a little bit about including the translation for patients who for whom English isn't a first language, but we put a lot of effort into making sure the trial was as inclusive as it could be, because in the real world, these are the patients that are turning up, and so if we are going to demonstrate a signal that it should be in a population as close to the population that it will be rolled out in as is possible. So I think these patients are right in the middle of the zone of patients that you should be enrolling in HEAL COVID for that very specific reason, or those two reasons. But again, there is some local variation on practice on this, and that's not unreasonable either.
So I suppose arguably we have a bit of an ethical obligation to consider these patients and by no means just dismiss them because it's not an easy process to recruit them. I think it's, like Mark says, having a diverse and representative population in the trial is really important.
But also we've made a lot of effort to try to not exclude disadvantaged minorities or populations in the trial, and so from that perspective as well, both the ethics and from a practical application in the real world, it is important that consideration is given to that.
So, as Mark just alluded to, patients who don't speak English as a first language can still be enrolled. But how does the consent taking process work, and also the PROMs? So this is the patient-reported outcomes when patients, after enrolment in hospital over the next few weeks and months, either have phone calls or answer questions on an app.
So we're quite proud of this one. We've taken the 7 most commonly spoken other languages in the UK, and there is translations available for all of our documentation and consent forms in all 7 of those, and the option for follow-up are as equally as diverse. So we have a translation line on our telephone follow-up schedule that allows us to be able to follow up the pro data in those 7 languages. But remember, the pro data is an optional field, so you can still be enrolled in the trial and not opt to carry out the pros, because the primary endpoint is collected digitally through NHS Digital or the equivalent structures in the devolved nations. So we have mechanisms in place for consenting all 7 of those languages and then following those patients up in their language of their primary language. But you also don't need to follow them up with the problems if they opt out of it.
Okay, so a slightly more niche one perhaps. So this patient tested positive over a month ago in the community. She is still chronically and persistently testing positive on PCR swabs now, for example, due to immunosuppression. Could she be enrolled?
So the question, it looks like a different case, but it's not. So the same case as earlier, I guess. And the question is just, are the patients symptomatic and is it an index admission for COVID? The answer to those 2 questions is yes. It doesn't matter that she's been persistently positive for several weeks. And if you think about some of the patients we enrol anyway, they come in, they're very unwell, they're in for weeks and weeks before they are then discharged and enrolled in HEAL, and so it's not massively different from that. So again, this is a high risk group with a high burden of morbidity and mortality down the line, and so this is another group that we definitely shouldn't be excluding and definitely should be considering.
So I suppose, again, just ticking those 2 boxes of, are they testing positive for COVID and are they symptomatic or unwell from COVID at this point? Okay, this eligible patient is likely to remain in hospital for another week or so for social reasons. Can we just enrol him now?
So it kind of depends on what your hospital setup is. It's the therapy is triggered on the date of discharge, so you can enrol them and then still set them for when they are discharged from hospital. But there are hospitals where you have a discharge to hospice, for example, or a discharge to a secondary care institution. As long as that is a discharge episode, then it still counts. We did look at whether we could include some of the non-secondary care organisations, and in fact a number of them came and spoke to us because they were quite keen to be included, but the technical barriers to doing that were quite significant, so we weren't able to resolve those.
Again, from a practical point of view, I'll just point out here that if you do end up recruiting a patient particularly early on in the admission, that's fine, but just make sure there's some sort of mechanism with prescribing that the trial drugs, if they're assigned to one, only kick in at the point that the patient goes home, so they don't sort of by mistake in the system start the apixaban during hospital stay, for example.
And that was one of the reasons that we tried to specify a time frame close to the end of discharge. It was to avoid you enrolling a patient being in for 2 months, everybody forgetting about the fact that they're on a trial, or them ending up in a completely different ward under a different team, and therefore delinking from the original enrolment. So as we move to clarify that, there maybe have to be a bit of work done in some centres to make sure that there's a robust process for keeping that link. But we already know that it's an imprecise art being able to define when someone is likely to be discharged, which is why we use soft vocabulary and not hard vocabulary in the inclusion and exclusion criteria, and that occasionally people will deteriorate. So someone will be looking like they're on the mend and looking like they're going to go home and then take a turn over the weekend and be in for another few weeks, and that's the real world. Those patients remain within the trial and would still be expected to be enrolled on discharge if they do end up being discharged.
And I think just simple mechanisms like that, the moment that you recruit a patient, I would update the discharge letter at that point, so it's really clear that if the patient stays in for another few weeks, regardless of what happens, on the discharge letter and the TTA drugs, it's still very clearly documents on there what the plan is. Okay, so again, Mark touched on this earlier on. So this patient is already enrolled in recovery as an inpatient. Can they also enroll onto Heal COVID?
So Heal COVID was set up to be complementary to recovery. Recovery covers the hospital space, or primarily the hospital space. Heal COVID, the post-hospital space. And it was so explicit that Martin Landry is one of our co-investigators and has been very important in helping us set up and deliver the study. We have allowed co-enrollment in recovery, so there is absolutely no reason that when you approach someone and enrol them in recovery, you can't already be talking about Heal COVID for their discharge. And in fact, I would strongly advise centres that aren't linking the two to link them, because it makes it easier to have that discussion, to keep track of them. We had hoped that the majority of patients that ended up in recovery would then transition to Heal, and that's not quite how it's worked out, because it is a diverse, complex set of patient trajectories in different hospitals, and it can be difficult to put the two together often, because it'll be different teams, for example, that will be enrolling, or it might be different wards, or maybe even different directorates. But the intention was always to make this a complementary study to recovery, and everything we did in the design of it was intentionally set up to be confluent with recovery, and recovery is one of our allowed co-enrolled trials. So I would strongly ask everybody to keep the two trials in their head together, and that anybody approached for recovery should automatically then be approached for Heal, because you already know they are trial positive patients. They are patients who are prepared to be enrolled in an inpatient trial, and we know that their mortality and morbidity doesn't stop when they're discharged, so it's still relevant to enrol them in a follow-on study.
And there's so much overlap as well in terms of the work to recruit to both trials, in terms of eligibility assessments and going through the drugs and so on, that you've almost done the job twice, so that it makes it more efficient. And just to highlight, this is taken directly from the protocol. So this is the list of 4 studies which explicitly patients can be enrolled for Heal COVID, and these are recovery, remap, FOSP, and ICERIC as well. But there's a note at the bottom just to flag up that if there are other studies which the patient's being considered for, just drop an email to Mark or to Charlotte, and these can be considered on a case-by-case basis.
And we have taken a number of additional studies and formally assented to co-enrollment, and we take a very positive view of that.
Okay, next question. This patient would be happy to consent to apixaban for 2 weeks, but would not agree to consenting to taking atorvastatin for a year. Can I just remove the statin arm from the randomization, or could we reduce the duration of statin therapy?
And again, this is a relatively straightforward answer, and it's no and no. And we don't want to bias the study by enrolling patients and having a set of patients not prepared to consider the atorvastatin arm. This hasn't emerged, by the way, as a major factor, I don't think, although there was a lot of talk about it at the start. I think now there are different reasons why sites are struggling. And I can see that from a patient's perspective, there will be patients who look at these arms and see them as unequal. Remember, Heal COVID was always intended as a platform trial, and there will be further therapies coming down the line. So eventually it is likely we will read out first for apixaban, and that the next set of therapies will be more chronic, and therefore there will be more equality between arms. But this has been a relatively small proportion of patients, and would exclude them from the trial, I'm afraid.
I suppose just to add that, though, it's probably, as with anything clinically, it's probably worth just exploring what the patient's concerns would be. Not to unduly persuade them to take part, but just in case there's any misconceptions about what atorvastatin is and the duration of it. So this patient will be discharged home with apixaban for a COVID-19 related PE that was diagnosed during this admission. Does this mean they're excluded from enrolling? And just to say, this links to one of the eligibility criteria on the protocol is worded as excluding patients who are treated for COVID-related complications, I think. So it's worth just clarifying this one.
So this patient would be arm excluded, but would still be enrollable within the trial. And I think the point about this was your centre has to have equipoise about the treatments for COVID, but not for licensed indications. So if, for example, your centre was giving everybody apixaban for COVID, that isn't equipoise, and therefore you can't run a trial. If your centre felt strongly that atorvastatin needed to be prescribed for everybody that came in with a troponin rise, then that would not be equipoise, because we know that a significant proportion of patients have a troponin rise in COVID, and there is no clinical evidence yet that giving them atorvastatin is of clinical benefit. So this patient would still be enrollable, but you would exclude them obviously from the apixaban arm, and hopefully that's clear. Yeah.
I rethink this question as being, is the drug being used for the license that it is approved for?
Or are you just using it for COVID? And if you're using it for COVID, then that's a challenge, and that's a problem, because it means there's not equipoise to run the trial.
Okay, so sticking on the theme of anticoagulants, is it okay for this patient to be given inpatient low molecular weight heparin prophylaxis if they are likely to be eligible for Heal COVID on discharge?
So inpatient prophylaxis is not a problem. Discharge low molecular weight heparin is, and there are a number of centres where that has been a problem, because the guideline committees might have been written a year ago, and at the time there was a lack of clarity over what the right thing to do was. There is still some divergence in some of the recommendations from our structures out there. So, for example, the BTS has beautifully lined up and made it crystal clear that patients should be prioritised for entry into Heal COVID, because we don't have an answer to this question. The problems we've had have been with the NICE guidance, where they've got a soft recommendation for anticoagulation, but have then made a PICO question that effectively is Heal COVID. So on the one hand, they are telling you this is a prioritised research question. On the other hand, there's some soft recommendation for post hospital anticoagulation. Anytime we have gone back to a guideline committee in a hospital and explored this in an open way and without challenging it, but just asking them to think through the implications of it, they have all acknowledged that it's reasonable to have Heal COVID open and for no treatment to be standard of care. I'm yet to come across a guideline committee that I've had an interaction with who've said, no, we don't agree with this. But So if you have that at your local hospital, that's the way to address it, is you go back to them and you have a discussion with who wrote the guideline. And I'm happy to be involved in any of those discussions if you want to bring me in to clarify the purpose of HEAL and some of the ontology behind the trial and some of the interactions with some of the guideline committees. But that hasn't been needed an awful lot, because most of the haematologists are pretty sensible. And when you go back and and explain the situation, they have been pretty reasonable and flexible.
Which I think covers exactly the same point. So for centres who are taking part in HEAL COVID, there shouldn't be an issue with patients going home routinely with any sort of anticoagulation. So if there are issues, and this is something that's flagged up to us occasionally by the APIs, let us know, and we can discuss.
And if you need our help with those discussions, we don't go in. We go in pretty softly, and we just explain the trial protocol, the existing evidence, the guideline recommendations from the different societies, and it's really just for information, for an understanding of the trial, rather than to go in and hector everybody to change their policies.
Okay, I think this might be the last one, or close to the end. So apparently I need to sign off the eligibility screening done. So this is a PI. I need to sign off the eligibility screening done by my physician associate colleague for HEAL COVID, but this is not the case for recovery. Can you clarify? So
we did originally try to get this as part of the protocol, but the MHRA insisted, and unfortunately the recovery and HEAL, this is one of the differences between the two. So unfortunately, there's nothing we can do about that. It still needs to be medically qualified to sign off. But remember, sign off, that process can be remote, doesn't have to be direct. And most of the trial is data collection, for example, is remotely delivered. So hopefully there are practical solutions to that. But we tried at the very start, and that was a hard stop, because I think the MHRA, although they let it through with recovery, then had some reflection on what they wanted as their kind of standards.
Okay, so we'll just run through a few overarching bits of advice regarding the eligibility assessments. So hopefully we've demonstrated that generally there are more patients who are likely to be eligible than you might initially think. There should be no grey areas, and again, when any of these queries are mapped against the protocol, it should be a very definite black and white: this patient is eligible to take part or not. And again, everything's in the protocol, hopefully. So that's going to be the first point of reference for any uncertainty. The use of clinical judgment, I think we've highlighted here a few times that, as with any decision really in medicine, if you're prescribing something, you have to be comfortable with that, weighing up the risks and benefits. And there's always going to be scenarios that are the niche perhaps and don't quite cover the protocol. So using your own clinical judgment or asking one of us for a second opinion, for example, would be a sensible thing to do.
I'm just highlighting that at the very start of the study, I took a lot of these calls, and I guess I haven't taken many of these calls recently, and I haven't challenged in my own head why that was, but I am always happy to be emailed, to be contacted for if you want some clarification, or if you want a further exploration of some questions related to eligibility. Much happier to be asked than not to be asked and miss the possibility of enrolling a patient. So both me and the HEAL team, the generic HEAL COVID and Liverpool email inbox should answer you pretty quickly and get back to you. And I've taken a lot of those calls, usually over the telephone.
And hopefully that shouldn't feel like a lot of additional work. It's hopefully just a quick clarification by email. So joint decision making with patients is again something that we have highlighted where that's appropriate. So obviously, as we said, patients can't opt out of ARMS, but it's sensible to have a risk-benefit discussion with the patient if there's any uncertainty. Safety is obviously the priority with clinical trials as the fundamental principle. Again, we've highlighted try not to fall into the trap of avoiding difficult cases and introducing bias to the trial in doing so. So we really need a diverse and representative cohort from this. So that includes patients from all walks of life, so not just focusing on the young, healthy patients who don't take lots of medications. We want to include as many different people in this as possible.
And we will, I think there's some additional questions in the chat. We'll deal with them at the end. Joe's got a few slides, and then we'll open up the floor.
I'll wrap up in a few minutes. If in doubt, as Mark said, please just drop us a quick email and we can give another opinion. Just before we open the floor, I just want to flag up the pitch for APIs as we always seem to do at meetings, given any opportunity to. So I'm sure many of you already know what the API scheme is. For those of you who don't, it's run by the NIHR and is plugged into a specific clinical trial of which HEAL is registered. The idea is that it is a mentorship or apprenticeship in which any healthcare professional who does not work in research as a primary role works alongside a PI to train up and learn what that involves. It's a 6-month attachment placement, and the idea is that you attend meetings, you help with screening eligibility and recruitment and so on. And it's part service delivery and significantly part of it is education, and we run monthly educational meetings for the APIs, and everyone involved will be acknowledged as part of the wider HEAL COVID group in publications in the future. And it's a really well accredited scheme and something that I would recommend. We have seen, I don't think we've got any data on this today, but we've seen that sites who have an API significantly recruit more patients than sites who don't have an API. And yes, there may be biases within that, but we see it such a significant difference. We really do believe that APIs can make a big difference to your site's recruitment numbers. I put a QR code on here. This is a slide from a while ago. I think it takes you to a YouTube video. It's about a 1-minute kind of little animation from the NIHR, which shows you a bit more about the API scheme and has links to the applications and stuff. So that's worth looking at. Just to flag up that we currently have 37 APIs who are either active or have been through the scheme from across the 4 nations, across a whole range of medical specialties, predominantly respiratory and intensive care. And they are generally doctors, so we've got higher specialty trainees and SHO equivalents, but also pharmacists and physicians associates. And we're keen to particularly target nurses for this, as we feel they're slightly underrepresented and could be a really great addition to the API network. This is quite a striking figure from the recovery study, who also really made the most of APIs, that 97% when surveyed will remain engaged in research in the future. So we really do hope that a lot of the APIs go on to continue with clinical research. Just a quick plug for the HEAL COVID Twitter and YouTube channels. There's some material going on there. The tweets of the month is something we do the APIs, and just to flag up a few things on here, there's some stuff about admission data and deaths. And the newsletter from April showed that Bristol and Bindesfield were joint up at that point, and I think then Bristol went ahead and recruited their 100th patient, which was fantastic. So this is a tweet from Emma Straston, their PI. And then a celebration from the NIHR that there's been 1,000 APIs from various trials from across the UK. So it's kind of a nice community to get involved with and see all the different research activity that's going on there. Okay, so just to wrap